If the greater auricular nerve seems inappropriate, for example, if the segment needed is longer, then in that case you will use a sural nerve. Okay, sural nerve. And the way this is being used is what is known as cable grafting. Okay, this is what is called cable grafting. Okay, and another thing that you can do is you can do a facial nerve anastomosis with the hypoglossal nerve. Okay, all these are beyond the discussion from your level, so I am just completing the discussion here. I'm not going further to make you more confused, but you have to know what is this cable grafting. And whenever you see a patient after the mastoid surgery having a facial nerve palsy, the first thing that you have to suspect is if it is due to a local anesthesia. In that case, if the action of the local anesthesia wears off, the patient will have no problem at all, and you will have to remove the mastoid dressing to relieve the edema, and you have to give steroids to relieve the edema. And even after giving the steroids, the patient is recovering, you will have to go for surgery. And for that, the patient being waited for the edema to relieve can be done if the surgeon is sure that he has not injured the facial nerve. Okay, so these are little things that you have to remember. And coming to certain tests that are being done for assessing the integrity of the facial nerve. The first test that you have to know is the nerve excitability test. What you are doing is you are giving an electrical impulse to the facial muscles, that is the muscles which are being innervated by the facial nerve, and you are trying to assess the minimum current that is required to elicit a response in the form of twitch. Okay, so this minimum current is being compared with the opposite side, and if this minimum current is more than 3.5 milliampere, then it is significant. Okay, it is indicative of there being a facial palsy. And maximal simulation test, instead of the minimum current being given, what is being done is you are giving maximum current that is possible to the patient, and we are trying to assess how the response is. This is compared with the other area, the opposite side, and with the opposite side you can give it as decreased, normal or increased. It's comparison. Okay, but these two tests are not done much. It is the electroneuronogram and the electromyogram which are the most important. And in electroneuronogram, what you are doing is you are actually keeping an electrode at the area of the stylomastoid foramen. The recording electrodes are used around the orbicularis oculi, and the compound muscle action potential generated is being recorded. And if there is more than 90% degeneration in day 14, then that is very significant, and you will have to go for decompression. So this is having a prognostic significance. Okay, prognostic significance. You can assess if the patient is having a better prognosis. If the degeneration is less than 90%, there is high chance that the patient may recover. Okay. Now in electromyography, what is being done is you are looking for whether the patient is having the fibrillation potentials or not. Okay, the normal course what is happening is that in the first 3 days you will have Wallerian degeneration occurring. So in those 3 days there is no use of doing any tests. Okay, it will have a varied result. Only after the Wallerian degeneration is complete, on day 3 you can do the other tests. Okay, in electromyogram, what you are doing is you are looking for polyphasic muscle action potential, if it is there or not. Okay, polyphasic muscle action potential. Instead of that, there will be fibrillation potentials occurring. Okay, fibrillation potential may occur when there is denervation, and later on when renervation occurs, renervation potentials will be seen. Okay, and if there is no chance of regeneration or recovery, then at the area of motor end plate there will be no response seen. Okay, so this is another thing that can help you assess the response. Okay, so if there is no response seen, there is no use of doing a nerve transfer procedure. You will have to go for a direct muscle transfer, like masseter muscle transfer or temporalis muscle transfer. Okay, instead of using a nerve graft or anything else like that. The nerve recovery is less chance of occurring. Okay, and for the patient's eye closure, you can even use gold implants. Okay, gold is relatively having no chance of any reaction with the body, so that is why a gold implant is being used for that. Okay, now if a patient comes with facial palsy, if it is partial, okay, progressive, you can give steroids as well as acyclovir. If it is not resolving, again you have to go for CT or gadolinium enhanced MRI, because gadolinium enhanced MRI will help you look for a schwannoma. Schwannoma can occur in the facial nerve. Okay, this schwannoma of facial nerve had happened in my post-graduation days in a patient who presented with facial palsy. On detailed evaluation, he was seen to have a schwannoma, and this patient was operated and a cable graft was kept, and the patient later recovered, not completely, but yes, he recovered. Okay, now when the patient is having vesicles along with facial palsy, that means it is a Ramsay-Hunt syndrome, right? Even for Ramsay-Hunt syndrome, what did I tell you? You can give steroids as well as acyclovir, and if more than 95% degeneration, you have to consider decompression. Less than 95% degeneration, you can taper the steroids. Okay, even if there is no vesicles also, it is the same course that is being done here. Okay, and post-traumatic wavejet paralysis is more than or equal to 21 days, and if the CT evidence severe disruption of facial canal, in that case you have to go for a surgical operation. Okay, if less than 21 days ENOG, then you can proceed as a complete palsy. Okay, these are the various things that you have to know in case of facial palsy. Now coming to the recovery of the facial palsy, it can be a complete recovery or a partial recovery. In that case, you will need to do a tarsorrhaphy to the patient, right? And what else can be the consequence of the recovery? It could be a synkinesis, that is aberrant regeneration can occur, and that can result in various problems like the crocodile tears. What is this crocodile tears? What is happening? Crocodile tears, what is happening is that instead of the normal secretomotor supply to the submandibular salivary glands, what is happening? The nerve fibers that are regenerating are going into the lacrimal gland, and it is going on to supply the lacrimal gland. Okay, so what is a normal secretomotor supply? You can see that superior salivatory nucleus. I already told you superior salivatory nucleus is for the one which is seen above. What is that? It is the facial nerve nucleus, and from that you have the nervous intermediate, which is the sensory part. Okay, and it goes into the genicular ganglion, and from that you have the greater petrosal nerve. This is the greater petrosal nerve. Okay, and from here you have the chorda tympani, and from through the chorda tympani it goes into the lingual nerve. This is the lingual nerve, and via the lingual nerve it supplies the submandibular ganglia. Okay, now what happens when there is a facial nerve injury, and if it is recovering like this, it goes on to innervate the greater petrosal nerve, from which it is going to the lacrimal nerve finally, and that can result in a lacrimation of the eyes. Okay, unknowingly, that is when you are eating, there can be lacrimation of the eyes. That is what is called gustatory lacrimation. Okay, so this can happen because of synkinesis and aberrant regeneration. What is other thing that can occur? You can have something called Frey syndrome. How do you diagnose a case of Frey syndrome? Frey syndrome is nothing but a case where you will have gustatory sweating, that is, while you eat there will be sweating. In the other case it was gustatory lacrimation that is happening, that is why it was called crocodile tears. Here what is happening? Here it is gustatory sweating that is happening, and it is confirmed by the test. What is the test being done? This is what is called as minus starch iodine test. Okay, this is called minus starch iodine test. And yes, what is happening here when the facial nerve is recovering, the postganglionic fibers which are normally going to the auriculotemporal nerve, instead of going there to supply the parotid gland, what is happening? It is going on to supply the sweat gland. Okay, it goes on to supply the sweat gland. And where is the sweat gland seen? It is seen in the area of the dermis of the in the area of innervation of the greater auricular nerve, as well as the area being supplied by the mandibular nerve. Okay, all those areas are having a secretomotor innervation for the sweat gland as well, but the only difference it is being supplied by the sympathetic fibers. All other glands are being supplied by the parasympathetic fibers, whereas sweat gland is by the sympathetic fibers. Okay, and because of the aberrant regeneration, what happens is that on eating there will be sweating over here, and this can be identified by the test which is called the minus starch iodine test. What you do is you will be keeping starch all over the face, and then you will be putting iodine, and they begin to react only when the sweating happens, and the sweating happens due to greater auricular nerve in the area of angle of mandible, because it is the area which is supplying the angle of mandible, whereas auriculotemporal nerve is for the area above that. Okay, so the answer to this question is greater auricular nerve. Okay, so what are the things that we learned today? We learned about the various disorders associated with facial nerve palsy. It can be a Bell's palsy, or it could be an herpes zoster. It's also known as Ramsay syndrome, and the treatment is steroids plus acyclovir. We learned in detail about the temporal bone fracture. Now, how will you manage a case of temporal bone fracture? Whenever you are suspecting a temporal bone fracture, it is advised not to put any ear wick to stop bleeding, because there is high chance of case of otorrhea, and that can result in meningitis. Okay, usually temporal bone fractures resolve spontaneously, but if there is a bony spicule going on to injure the facial nerve, you have to do immediate decompression. You will have to immediately remove that segment. Okay, so facial nerve decompression is very important. Okay, so that is another thing that we learned. Now we learned about the various techniques to assess the prognosis of facial palsy. There is electromyogram and electroneuronogram. Okay, and what else did we learn? We learned about the other causes of facial palsy, like the congenital palsy, Melkersson-Rosenthal syndrome, and Hereford syndrome. Okay, and so we now know a nutshell about the whole of facial nerve. Okay, please go and read today itself, because this is very, very important. The facial nerve anatomy as well as the various disorders that are associated with facial nerve, and it is being asked multiple times for the various competitive exams. For now, goodbye.